My name is Dr. Dempsey, and I am going to be talking to you today about Introduction to Neuropsychological Screening Assessment. And we'll go into all of that in just a second. So before we begin, if you're already doing neuropsych assessment, a lot of this will be a primer for you. We're going to be talking about screening. If you haven't done any type of neuropsych assessment, then this class will be really good for you because we're going to be talking about how to implement neuropsych assessment and bringing it into your current work and practice. We're going to be doing all types of different things today. I'm going to be showcasing some specific tests. We're going to be doing them in class, and then we're also going to be talking a lot about how to interpret. I am doing this class because I was asked to, in essence. Some nice people from Parole Outpatient Clinic requested that I bring them up to speed with testing and assessment. So some of the information that I'm going to be talking about today is going to be pertaining to forensic work, which I think is really good for everyone because, you know, we should all kind of be up on that as well. So the purpose of this CE manyfold. As I just said, I want to bring you up to speed with neuropsych screening assessment and prompt your knowledge. If you're really interested in neuropsych, maybe you found a second career, you want to go back and get some more information about that. We're going to be covering all types of things, specifically things like dementia and ADHD. I don't know if your evaluations say learning disabilities on there. They shouldn't. They should say TBI instead of LD. So you can take note of that because those are the three areas that we're going to be talking about today. And then, in addition to this class, I have a website, racheldempsey.com, and if you have /QA or just go to the front and hit questions, there's a forum there that you can post any questions that you might have that are about testing and assessment that you want either peer input from or just my answers to. If you emailed me directly, that's totally fine. If it's a good question, I'll put it on there anyway, anonymous. And that way you can continue getting more information about testing and assessment. This is a caveat that I wanted to throw out there. It says, when evaluating tests for screening purposes, it's important to realize that although neuropsychological tests have proven effective in identifying the presence of brain disorders, they cannot guarantee its absence to rule out brain dysfunction. In essence, absence of evidence is not evidence of absence. Meaning that what we're teaching you today is just screening. The screening might show that there's nothing going on. That does not mean there's nothing going on. The screening might show there's a lot of things going on. That might not necessarily mean that there's a lot of dysfunction there. And the reason why I throw that out there is because I don't want you to give a screening assessment and think you've got a diagnosis. You might, you absolutely might, but more likely than that you have a provisional diagnosis, or you can put rule out. You can also use things like cognitive disorder NOS, mild cognitive impairment, to cushion it as opposed to something like dementia. The reason why is if you give the diagnosis of dementia, it might close doors. If another treatment provider picks up your report and sees that this person was previously diagnosed with dementia, that's a deteriorating, in essence, disorder, and that person's not going to be recovering. When in actuality, what if that person was depressed? So if that person has major depression and you missed it thinking it was dementia, that person's now not going to be treated for the depression. All right. So that's why I want to caution you that this class is to teach you about screening assessments, not a full Halstead 10, and it's not to take the place of more in-depth assessments or something that would be going on with, say, a neurologist. You could put dementia rule out, and in the whole conclusion section, talk about why you think it could be dementia or could be something else. Those are two of the things that you can talk about. There are many, many different consequences for making false positives and false negatives. Just be aware of that. If this CE sparks an interest in neuropsychology, I highly recommend that you join some of the clubs. Go to some of the continuing education classes that are out there. take some more classes, and learn and build and grow. All right? These are some of the forums and associations that are out there that are specific to Neuropsych. Also, there are 2 accrediting agencies that you might be interested in. If you're interested in becoming a board-certified neuropsychologist, there's the American Board of Professional Psychology. The subset is the American Board of Clinical Neuropsychology. So the ABPP is an umbrella for currently 13 different schools, if you will, and one of those is the ABCN. They go by something called the Houston Conference, and if you're interested in becoming board certified under ABPP, American Board of Professional Psychology, ABCN, then you need to meet these criteria. If you don't meet these criteria, specifically what I'm saying is an internship in neuropsychology, if you didn't get that before you were licensed, then the American Board of Professional Neuropsychology, the ABPN, is the other accrediting agency, and they require at least 3 years post-licensure, postdoctoral work in neuropsychology. Both of these accrediting agencies are grueling to get into and get board certified. You have to pass a written test, you have to pass the Neuropsych test, and you have to submit professional work. In addition to all of that, you've got to have a huge application before all of that. You have to pass the huge application. They have to accept you and invite you to come and take these tests. So board certification is the gold standard, and I highly recommend if this is an area you want to pursue, go for it.